Very good evening to all the doctors who have joined us today online and offline since it is a digital program. I'm Dr. Pallavi and I'm a medical advisor at Emcure Pharmaceuticals. And I have with me my marketing colleagues and medical team, seniors from medical team. And on behalf of Emcure Pharmaceuticals, I would like to welcome you all delegates for this program on international speaker program today. And Emcure is committed to make India iron strong and has taken this initiative to introduce one more molecule, that is ferric maltol. And as a speaker for today's program, we have Dr. Professor Kashan Smith, and who has done extensive research on this molecule, and he's been using it since 8 years. And it will be great to listen from him about his experience on this new molecule, that is ferric maltol. Though it is new for us, but it is not new for Dr. Kashan Smith. And I would also like to welcome our moderators for today's session, Dr. Balamba ma'am and Dr. JB Sharma sir. Let me introduce and share my screen. Dr. Balamba ma'am is a consultant obstetrician and gynecologist, Professor Emeritus at Obstetric and Gynecologist at NTR Health University, and she has served as additional superintendent at Usmania Medical College, Hyderabad, and she has been additional director medical education for Government of Andhra Pradesh and has been served as chairperson for governing body of Prajwala Anti-Trafficking Agency, and she has also been a part of President of Obstetrics and Gynecological Society of Hyderabad 2006, and she is organizing person of All India Congress of Obstetrics and Gynecology 2011, and she has served as a past vice president for Family Planning Association of India, Hyderabad, and she is passionate about maternal mortality. She wants to reduce it, and she has been very interested in high risk pregnancy and has done a lot of field in the field of HIV particularly. And she has trained all the 13 medical colleges personnel and area hospitals and private medical colleges for PPTCT HIV, and she has conferred the British International Doctors Association an award as an award and honored by a Telugu Association of North America in 2007. Welcome, ma'am.
Thank you.
Also, I would like to welcome Dr. JB Sharma sir, and he is currently working as a professor at AIIMS New Delhi, and he was ex-professor of Maulana Azad Medical College, New Delhi. He has worked at Bartholom Hospital, Homerton University Hospital, and Whipps Cross University Hospital, London, UK for 4 years. And he has been awarded by BC Roy Award by Honorable President of India in 2015 for research in his research in obstetrics and gynecology. He has 350 publications in his name, and he is the author of textbook of obstetrics and midwifery and gynecological nursing, and he has written 5 chapters in John Sturt's Progress in Obstetrics and Gynecology, which was published for UK, and he was editor-in-chief of Obstetrics and Gynecology Today, and presently the chief editor of Journal of Pediatrics, Obstetrics and Gynecology, on editorial board of 6 journals, and presented over 200 papers and chaired sessions in various national and international conferences. And he has also won Indian Council of Medical Research Amrut Modi Unicame Prize for his research work on anemia during pregnancy. And he has been awarded as a Best Paper Award in 2003 for role of lycopene in prevention of preeclampsia. Welcome, Dr. JB Sharma, sir.
Thank
now,
you.
I would request Dr. Balamba ma'am to introduce Professor Kashan Smith and set the context and proceed further.
Thank you, Dr. Pallavi. Can I have his introductory slide?
Yes.
It's my pleasure to introduce Professor Dr. Carsten Smith, Head of Oncological Center of Fulda Hospital, Germany. He has a rich experience of more than 30 years He is an expert in gastroenterology, endocrinology, and diabetology, and his areas of interest are innovative diagnostic and therapeutic endoscopy, chronic inflammatory bowel disease, and umpteen memberships, so many memberships. He is, I think, in every society that is there in Germany and Europe. And I welcome you, Dr. Schmidt. And
Thank you, ma'am.
Immense experience in using this molecule, ferric maltol. And let us listen to him and see whether he has done all this research on people who have had inflammatory bowel disease and also other conditions, whether we can extrapolate it to our pregnant women who have no bowel problems. That is what we are going to listen to. Thank you. May I present Dr. Schmidt?
So, ma'am, I would request Dr. JB Sharma sir also, because he wanted to share a few points on the Indian context. So, yes, sir.
Yeah. Oh, thank you. Sorry, if you just give
Thank
me
you,
1
sir.
minute. Yeah. I welcome Professor Carsten Smith and Dr. Balamba for this. So, sir, Dr. Smith, we are very eager to listen to you. In fact, whole of the India, our people are there. So, just to set the ball rolling, basically, I'm Professor of Obs and Gynae, and we did a lot of pregnancy anemia. We had done a lot of work on that. So, unfortunately, anemia remains the, according to the Anemia Mukt Bharat program, according to NFH Survey 5, anemia increased. Actually, it was 53% in last year in India. So almost for 50 years, we have got National Nutrition Control Program of India, but still anemia remains so high in pregnancy, and there is no rocket science in it. There is no, like, everyone knows how to diagnose anemia by simple hemoglobin and simple blood indices. Everyone knows how to prescribe oral iron, and though we have got injectable iron, like, Emcure has come, FCM and all that, but still oral iron remains drug of choice. So why it is so that in spite of being given even free of cost by government of India, still incidence remains high. In fact, is increasing. So that the main reason is that most of the iron available in the market are not well tolerated by patients because of GI upset. So that's why Dr. Carsten's lecture will be very special. Actually, we really want a molecule. In fact, I have patients like doctors themselves, gynae doctors, who couldn't tolerate we tried 20 molecules to her and still she couldn't tolerate any molecule. So there is GI upset is there. It can cause diarrhea, it can cause constipation, it can cause abdominal upset and all. So they stop medicine altogether, though they may not be having any bowel inflammatory disease. So that's also this new molecule, ferric maltose. I congratulate Emcure to bring it out, and we are so happy that Dr. Carsten Smith is there, who has done work for more than 8 years. He has huge publications on this topic. So I feel that it may not be exaggeration if I say that ferric maltose may become a drug of choice in near future, even for pregnancy anemia. And there is need to do research studies on its role, but there is no reason why it should not be prescribed in pregnancy also. It's such a safe molecule. When we are prescribing ferric carboxymaltose injectable, we are giving, so ferric maltose I'm sure can be given orally also. So let's hear Dr. Carsten Smith. So for my colleague from all over the country, so we welcome Dr. Smith and hear to him. And I feel that this ferric maltose has a brilliant future, but we have to wait for that. Thank you very much, and welcome Dr. Carsten Smith and Dr. Balamba.
Yes, sir. Thank you, sir, for your kind words towards Emcure. So now I would request Dr. Carsten Smith to please take up your presentation, sir. Thank you.
Well, thank you very much, dear ladies and gentlemen, dear colleagues. First of all, I would like to thank you very much for the kind introduction as well as the kind invitation to the symposium, and to be able to talk about iron deficiency anemia, especially to talk about ferric maltol as a new treatment option, and to present not only efficacy as well as safety data, but also to talk about my personal experience with this compound that I am having now for, as you already heard, 8 years. This is a short representation of my potential conflicts of interest. Well, as you all know, iron deficiency and iron deficiency anemia are prevalent in numerous patient populations, especially with regard to women's health. We know that iron deficiency on a worldwide basis happens in up to 75% of patients, iron deficiency anemia in up to 40% of patients. And from the developing countries, we know that around 50% of pregnant women suffer from iron deficiency anemia. But there are many more populations suffering from this disease, not only older patients with an iron deficiency anemia rate of more than 20%, but also patients post-operatively, patients suffering from inflammatory bowel diseases, a patient group that I'm caring for on a daily basis. And we know that IDA occurs in up to 3 out of 4 patients. Moreover, in cancer and in chronic kidney disease, iron deficiency anemia is quite frequent. We come back to this point later on, as well as in patients suffering from heart failure, from who we know that it is also prognostically of high importance. As you all know, there are many ways to treat iron deficiency and IDA. On the left-hand side, there's a short overview about the pros and cons of traditional oral iron therapy. We all know that this kind of therapy is quite cheap, it is easy to apply, and it can be used throughout an especially women's life cycle. On the other hand side, it suffers from poor tolerability, from less efficient absorption, and therefore from poor compliance due to a large amount of adverse events, from abdominal discomfort to abdominal pain, like nausea or even vomiting, constipation, or diarrhea. Moreover, it is ineffective in the presence of high hepcidin levels, so in cases of an inflammatory condition, like inflammatory bowel diseases, and it has a high pill burden. On the other hand side, IV iron replacement therapy has far fewer GI side effects. It allows a faster iron repletion. It is associated with better compliance, and it is effective even in the presence of inflammatory disorders. On the other hand side, the costs are much higher. It requires a physician oversight, and there is still an even small risk of anaphylaxis, of hypophosphatemia, as we learned very recently. And of course, it cannot be used in the first trimester of pregnancy. And so the question remains if ferric maltol can meet all those requirements. We know from prior studies that the percentage of patients experiencing especially GI adverse events with oral iron therapy is quite high and is associated with the amount of iron uptake. The frequency of GI adverse events ranges between 30 and 50% of patients. So with regard to this novel compound, ferric maltol, and with regard to the intestinal iron absorption, we know that normally only about 5 to 15% of the non-heme iron taken up in food is already absorbed. The absorption rate increases with the level of iron requirement, for example, in pregnancy, up to 30%. However, absorption of non-heme iron from the GI tract takes place in the proximal portion of the intestine, mainly in the duodenum, and involves 4 different stages. First, not shown on this slide, gastric acid in the stomach releases ferric iron contained in food, and it is reduced to ferrous iron, either chemically by gastric acid, for example, or through the action of a duodenal enzyme, namely cytochrome B, which is a reductase. Second, either from nutritional iron or from iron salts, ferrous iron is taken up into the mucosal cells via the divalent cation transporter as shown here. The messenger RNA of this transporter is expressed mainly in the duodenum, and it is upregulated during iron deficiency or potentially downregulated in cases of iron excess. Third, once inside the intestinal epithelial cell, one of 2 processes take place within the cytosol. Iron either binds to the ferritin in the cellular iron storage protein, whose synthesis is closely correlated to the content of the mucosal cell, or iron is directly released by means of ferroportin 1 at the basolateral membrane of the cell. The hephaestine in the basolateral membrane of the epithelial cell, oxidizes ferrous iron to ferric iron. And so in the final step, ferric iron binds through transferrin, the plasma iron transport protein, so it can be utilized for erythropoiesis. The problem is that about 90% of iron is not taken up by the mucosa. And so the residual iron within the intestinal tract dissociates from the salt so that free ferrous iron is oxidized. Reactive oxygen species are generated, doing harm to the intestinal mucosa, for example, by means of peroxidation of the gut mucosa. Moreover, free iron contributes to gut dysbiosis, especially a reduction in microbiota diversity, as well as a reduction of protective short-chain fatty acid like butyrate producing bacteria, for example, among others, Faecalibacterium prausnitzii. On the other hand side, the mode of action of ferric maltol is somewhat different, even if not fully scientifically elucidated. The most important aspect is that the central ferric iron is surrounded by 3 maltol complexes, while maltol is a sugar derivative and a non-toxic substance. And in this compound, by chelation, it is the mucosal surface is protected from the direct contact to the iron in the center of this molecule. The process, as far as we know, occurs on the mucosal surface, and only after absorption of the compound, the iron dissociates from the compound, is further released into the epithelial cell and processed as described before. While on the other hand, the maltol complex undergoes a glucuronidation and is excreted mainly via the kidney. The main advantage of this complex is that iron remains chelated within this process, and so it is excreted, if not absorbed, via feces. It does do no harm to the intestinal mucosa, and it does not contribute to gut dysbiosis. So in summary, ferric maltol overcomes the limitations of ferrous salts, where up to 90% of ferrous iron is unabsorbed and undergoes oxidation in the gut, resulting in the generation of reactive oxygen species that cause mucosal damage and many gastrointestinal side effects, as already mentioned. In summary, ferric maltol remains in the complex throughout the GI tract until uptake at the enterocyte or excretion via feces. This stable complex forms a protective cage around the ferric iron. The iron from ferric maltol is absorbed and transported throughout the body for use, especially for erythropoiesis. Moreover, ferric maltol is well absorbed and can be given at lower doses, typically 30 milligrams BID, without compromising efficacy. So, but what are the clinical or the scientific data supporting the use of ferric maltol? A couple of years ago, we did a large phase 3 randomized placebo-controlled prospective study in 4 European countries, namely in Great Britain, in Germany, in Austria, and in Hungary. This is the study overview. We randomized about 128 patients suffering from inflammatory bowel diseases, namely Crohn's disease and ulcerative colitis. The patients were randomized to receive ferric maltol 30 milligrams BID or placebo for 12 weeks, when the primary endpoint was a change in hemoglobin concentration from baseline to week 12 and moreover to week 52. Importantly, after the first 12 weeks of treatment, all patients received ferric maltol in an open-label extension study for another 52 weeks. The key inclusion criteria were a confirmed diagnosis of mild to moderate ulcerative colitis or Crohn's disease and a mild to moderate iron deficiency anemia characterized by a hemoglobin concentration between 9.5 and 12 for females and 9.5 and 13 for males. The serum ferritin level had to be below 30 micrograms per liter at screening. And this is probably the most important aspect of this study, all of those patients previously failed oral ferrous products. I'll come back to this point later on. Key exclusion criteria were anemia unrelated to iron deficiency, a received depot iron preparation, erythropoietin or blood transfusion within 12 weeks of screening, oral iron within 4 weeks of randomization, treatment with immunosuppressants, folate and uncorrected vitamin B12 deficiency, and, as always in our studies, pregnancies. There were a couple of secondary endpoints I'll come back to later on. This is the patient disposition, and these are the patient characteristics. The median age of our patients was around 40, typically for patient populations suffering from IBD. More than 50% of patients were female, most of them of white ethnicity. About 45% of patients suffered from ulcerative colitis, while 55% suffered from Crohn's disease. The time since the last IBD flare was only between 6 and 9 months, and the time since the last oral ferrous product was between 17 and 22 months. The reason, and this is a very important aspect for OFP failure, was adverse drug events in 2/3 of patients. 2/3 of patients already experienced especially GI side effects. Moreover, lack of efficacy had been reported by roughly 1/3 of patients, and a couple of patients reported about the deterioration of IBD or had other signs of treatment failure. The mean hemoglobin level at study entry was 11 grams per deciliter, the ferritin concentration was below 10, and TSAT was around 10%. Concomitant medication consisted of mesalazine, which is very typical for patients with ulcerative colitis. About 10 to 13% of patients received prednisolone. Some of them received azathioprine as an immunosuppressive drug, or biologics like infliximab or adalimumab. Individual patients also 6-mercaptopurine, which is an immunosuppressive drug as well. So this is representation of the main results of the study. As you can see, there was no change as expected from placebo treatment, but a steep increase in hemoglobin concentration of 1.8, and finally 2.25 grams per deciliter after only 12 weeks of treatment. And the average time to hemoglobin normalization with ferric maltol was about 2 months. This is another representation of the main study results. After only 12 weeks, we found an increase in hemoglobin of at least 1 gram per deciliter by 78 versus 11% of patients receiving placebo, an increase of at least 2 grams per deciliter in 56 versus 0 patients with placebo, and the normalization of hemoglobin levels after 12 weeks has been observed by 2/3 of patients treated with ferric maltol. During the long-term extension study, this is the slide that I've already shown you. During the long-term extension of the study, where all patients received 30 milligrams ferric maltol BID, the patients who received placebo before caught up, so that at the final stage of this trial, about 13.2% and 12.5%, the hemoglobin concentration was about 13.2 grams per deciliter at the end of the study in the group of patients who received only ferric maltol, and 12.5 grams per deciliter in the group of patients who received placebo and ferric maltol afterwards. On the last image that I would like to show you, we summed up the percentage of patients who experienced hemoglobin normalization. As you can see, after only 12 weeks of treatment, more than 70% of patients experienced normalization of hemoglobin. At the end of the trial, patients who continued ferric maltol treatment achieved hemoglobin normalization in about 90% of those patients. Moreover, ferritin concentrations and TSAT concentration increased steadily and quite rapidly, and we showed on average a normalization of those two parameters at the end of the trial. But what about adverse events? As I told you, all of those patients already had the non-successful treatment with oral ferrous products. 2/3 of patients had experienced side effects. And during the placebo-controlled phase of the trial, so within the first 12 weeks of treatment, there was absolutely no difference in adverse events between the ferric maltol and the placebo-treated groups. Nominally, after 12 weeks of treatment, there was a slight increase, even if not statistically significant, in the placebo-treated patient. So in summary, the safety profile of ferric maltol was absolutely comparable with placebo, with no impact on disease activity in a very vulnerable patient population like IBD patients. In a second trial that we did subsequently, we compared ferric maltol treatment in IBD patients with ferric carboxymaltose treatment during a randomized, even not blinded, 12-week clinical trial. After 12 weeks, again, patients continued their treatment, entering a 40-week open-label extension study. 250 patients were randomized on a 1-to-1 ratio. The key inclusion criteria were quite similar, albeit a bit different. We included male and female patients at least 18 years of age with a confirmed diagnosis of quiescent, mild or moderate inflammatory bowel disease. They were suffering from iron deficiency anemia with a hemoglobin concentration between 8 and 11 for women and 8 and 12 for men, with a ferritin concentration below 30 or ferritin below 100 in this inflammatory condition, with the T-set of below 20%. Key exclusion criteria were as described for the prior study. Primary endpoint was the hemoglobin responder rate, which was defined as an increase in hemoglobin concentration of at least 2 grams per deciliter or normalization of hemoglobin, and there were a couple of other secondary endpoints. These are the patient characteristics as well. Median age was again around 40 years. More than 50% of patients were females of white ethnicity in our patient population. Somewhat more patients were suffering from Crohn's disease as compared to ulcerative colitis, and they had a mild disease activity. The Crohn's disease activity index was between 130 and 140. The cutoff value to a normal range is about 150. So a considerable number of patients already suffered from mild to moderate disease activity, and it was pretty much the same in patients with ulcerative colitis. The mean hemoglobin concentration, again, was around 10 grams per deciliter. The ferritin was between 9 and 17, so comparable to the prior study. Substantial number of patients received vitamin B12 or folic acid supplementation. About 1/3 already received corticosteroid treatment. Many patients received mesalamine. And again, there was a considerable number of patients treated with immunosuppressants like azathioprine or with biologic drugs like infliximab, adalimumab, or vedolizumab, which is an anti-integrin antibody. This is the main result of the study. As you can see, there was somewhat a small difference in response rates between the ferric maltol group in blue and the ferric carboxymaltose group in green. So the increase in hemoglobin concentration was somewhat faster in the IV-treated patient groups, so that non-inferiority of the oral preparation could not be proven. However, and this is from my point of view even more important, during the open label extension study, there was absolutely no difference in response rate. There was absolutely no difference in the mean change in hemoglobin concentration as compared to baseline. This is another representation showing that an increase of at least 1 gram per deciliter after 12 weeks was not different between the two patient groups, while there was slight differences in the patient criterion of an HB increase of at least 2 gram per deciliter on normalization of hemoglobin. With regard to adverse events, we again observed quite a low percentage of different adverse events. I don't want to read out all of them, just want to highlight that in summary, there was a slight increase in adverse events reported by the patient group treated with ferric maltol. But we should bear in mind that this was not a blinded study, so I assume that there is a substantial nocebo effect leading to this result, because in the prior randomized blinded study, as I mentioned, we did not see any difference in adverse events between ferric maltol and the placebo group. A third study that I would like to present to you is a study that has been performed in patients suffering from chronic kidney disease, namely in patients suffering from stage 3 and 4 chronic kidney disease, characterized by a glomerular filtration rate between 15 and 60 milliliters per minute. 167 patients were randomized in a 2-to-1 ratio, so that during a 16-week randomized controlled trial, 111 patients received ferric maltol, while 56 received placebo. After this blinded study, every patient received ferric maltol at a dosage of 30 milligrams BID for another 36 weeks. Primary endpoint of this study was the change in hemoglobin concentration from baseline to week 16. Key inclusion criteria were male and females of at least 18 years of age, an existing diagnosis of chronic kidney disease, as mentioned before, a diagnosis of iron deficiency anemia with a hemoglobin level between 8 and 11 gram per deciliter with respective ferritin and TSAT concentration. I think I'll skip the exclusion criteria and go over to the patient characteristics. As you can see, this patient population was somewhat older, between 65 and 69 years of age. Most of them, again, were of white ethnicity. The hemoglobin concentration, again, was around 10 gram per deciliter with a ferritin of 100 to 104. We should bear in mind that CKD is also an inflammatory condition. TSAT was below 20% with low serum iron concentration. The median glomerular filtration rate was around 30 milliliters per minute. This is the main result of the study. While there was no increase in hemoglobin concentration in the placebo group, after 16 weeks, there was a change as compared to baseline of 0.5 gram per deciliter in hemoglobin concentration. Again, depicted in this figure, you can see that there was almost no change in the placebo group and an increase in hemoglobin concentration. And during the second part of the trial, during the long-term extension study, the patients who received placebo before caught up again, so that after the entire treatment period, there was an increase in hemoglobin concentration of 0.7 and 0.5 gram per deciliter in the two groups, respectively. With regard to GI adverse events, summarized from all the pivotal trials that I showed you, we found that no individual adverse event occurred in more than 5% of patients, even if, as I said, many of those patients experienced AEs on ferrous products. In this table, you can see the individual percentages, but I'd like to sum up that a high proportion of patients taking ferric maltol completed 12 and 16 weeks of treatment in both the IBD and CKD studies. Neither short or long-term ferric maltol treatment led to iron overload, and the percentage of patients who discontinued treatment due to AEs was below 5%. Before I sum up those data again, I would like to introduce you to two of our patients that we treated with ferric maltol during the recent years. The first one is a female patient born in 1994, and she received a diagnosis of Crohn's disease only at the age of 15, involving the duodenum, the terminal ileum, and the colon. So it was a quite early and severe disease course. She received many courses of prednisolone, and she started azathioprine treatment in 2012, although she experienced multiple flares of her disease requiring steroid treatment. And so finally, she developed a stricture of a terminal ileum, which is a well-known complication of less treated or insufficiently treated Crohn's disease. Due to the complaints, the colleagues started adalimumab treatment, which is an anti-TNF antibody, but unfortunately, and due to the fibrotic stricture she already had, she did not experience response to this therapy. So the colleagues decided to perform a balloon dilation of the stricture, but unfortunately, an intestinal perforation occurred within this procedure, so the patient received ileocecal resection. Postoperatively, she received mesalamine treatment as a maintenance therapy. With regard to her past medical history, she only reported about a tonsillectomy in 2006 and about the treatment of iron deficiency anemia in 2014. First of all, she received oral ferrous sulfate, but she refused oral treatment due to side effects, so that the problem was resolved with the use of ferric carboxymaltose. She first presented to our clinic in November 2021, and she reported about 5 to 6 bowel movements per day. Among them, 1 bowel movement during night. She reported about loose stools, mild abdominal pain, and moreover, her general condition was reduced with a BMI around 21. She did not report about extraintestinal involvement, but in summary, she had an Harvey-Brechtshaw index of 7 point, which is or reflects mild to moderate disease activity. And in her stools, we measured calprotectin, which was far below the upper range of normal, far below 2,100 microgram per gram stool. You can see that she had mild inflammatory activity with a CRP of about 2.7 milligram per deciliter, leukocytosis, mild anemia, thrombocytosis. Ferritin levels were markedly reduced, as was the TSAT concentration. This is an ultrasonography of her bowels, and we observed in a thickening of the bowel wall, especially in the terminal ileum, and we moreover observed there was an increase in vascularization corresponding to the colonoscopic image, where there was nearly no inflammation within the gut, but there was substantial inflammation, swelling, erosions within the terminal ileum. So we decided to put her on adalimumab, the anti-TNF antibody, again with the usual drug concentration, and she achieved a rapid and durable clinical remission after only 4 months of treatment. The calprotectin was reduced from more than 2,100 to only 164, which is quite normal for patients with Crohn's disease. Moreover, we decided to treat her with ferric maltol in the usual dosage, 30 milligrams BID. And as you can see, within only a few months, there was a steep increase from a hemoglobin of 10.6 to 13.8, which was further maintained even after cessation of ferric maltol treatment, while she was in clinical remission with regard to her Crohn's disease. Moreover, ferritin and TSAT concentration experienced a rapid normalization. So did erythrocyte parameters like MCH and MCV. The second patient that I would like to present to you is somewhat more complex. It was a young man who received a diagnosis of Crohn's disease in 2018 and who had a pancolitis, so an inflammation of the entire colon. He received prednisolone treatment. He didn't respond to prednisolones. He had a steroid-dependent disease course. We were not able to stop prednisolone treatment, and so we decided to treat him with vedolizumab, which is an anti-integrin antibody licensed for the treatment of Crohn's disease. He did not experience surgical treatment before, but he reported about peripheral spondyloarthritis, especially of his right knee, which responded to steroid treatment. With regard to his past medical history, well, he had a great number of diagnoses. The most important is that he, since he was a child, was suffering from congenital nephrotic syndrome in infantile focal segmental glomerulosclerosis, which is a podocyte-associated disease that resulted in terminal chronic renal insufficiency requiring peritoneal dialysis. And finally, he received a first allogeneic living donor kidney transplantation in 1996. Unfortunately, he experienced the florid interstitial rejection and a chronic graft dysfunction. So in 2001, he successfully received an allogeneic living donor kidney transplant from his mother, which is doing really well. I just saw him this week, and he had a creatinine concentration of only 1.4 gram per deciliter after 14 years now. However, he experienced iron deficiency anemia. He intermittently took ferrous iron products, and he experienced the well-known adverse events, so refused to take this medication again. Upon presentation in February 2021, he reported about 7 to 8 bowel movements per day, among them 1 to 2 bowel movements during night. He reported about frequently loose stools, often bloody stools, mild abdominal pain, and a reduced general condition with fatigue. He had an activated peripheral spondyloarthritis of his right knee, so the Harvey-Bradshaw index was even higher, around 9 points, and the calprotectin was again very high. CRP was markedly increased. He showed leukocytosis, anemia, and thrombocytosis. The creatinine at this point was 1.5 milligram per deciliter, and he had very low ferritin concentration, and the TSAT that was not able to be calculated because there was nearly no iron within his blood. With regard to his medication, he took prednisolone and tacrolimus after renal transplant. Because of arterial hypertension, he took propranolol and ramipril, pantoprazole for the protection after multiple gastric ulcers, and the supplementation with vitamin D and L-thyroxine. Moreover, he received cotrimoxazole as a prophylactic antibiotic treatment due to the multiple immunosuppressive drugs. This is a colonoscopic video from this patient. You see typically for Crohn's disease that there are areas of normal colonic mucosal surface, but also erythema, swelling of the mucosa, sometimes smaller, sometimes deeper, as on the left-hand side, ulcerations within the colon, and then again there is a proportion of colon with a normally appearing surface, little pseudopolyps, typical for a patient with Crohn's disease. Well, we decided to put him on ustekinumab, which is an anti-IL-12, anti-IL-23 antibody at a usual dosage, and he experienced a rapid and durable clinical remission until today, until this week, and the calprotectin decreased to 183, which is quite normal for a patient with Crohn's disease. Due to this higher disease activity at the beginning, we decided not to start with ferric maltol, but we gave him a single infusion of ferric carboxymaltose and then changed to the oral treatment, especially due to his poor venous access. And as you can see from this figure, he also experienced a steep increase of hemoglobin concentration, which was further improved by treatment with ferric maltol. And with regards to ferritin and TSAT concentration, we saw a steep and sustained increase of those two parameters. And again, we saw normalization of MCH and MCV in this patient. So, ladies and gentlemen, finally, please let me conclude. I think I have shown you that traditional iron treatments for ID and IDA are limited by poor tolerability, which negatively affects patient adherence and subsequently treatment efficacy. On the other hand side, ferric maltol is a new chemical entity that overcomes those limitations of poor tolerability associated with conventional oral iron treatments. Consistent evidence, as I show you, in various patient populations, mainly in IBD patients and in CKD patients, shows ferric maltol provides clinically meaningful improvements in hemoglobin and measures of iron availability with a low frequency of adverse drug reactions. Less than 5% of patients discontinue treatment. Ferric maltol, therefore, is a novel, low-dose, effective, convenient, and durable and well-tolerated treatment option for resolving iron deficiency and iron deficiency anemia. And with that, I thank you for your attention very much, and I'll be happy to take any further questions.
Thank you very much, Dr. Schmidt. It was a very elaborate talk. And now I think, we'll wait for the questions to be tabulated by Dr. Prashant. And meanwhile, let us know about this conventional iron, naturally ferrous sulfate. It gets converted into ferric and ferric to ferrous. And because of this, there are the reactive oxygen species are released in the stomach, and that causes the adverse events. And of course, the iron gets absorbed only from the first part of duodenum. But then, meanwhile, because of this iron being very unstable, it can receive an electron and it can donate also. And that is the problem, from ferric to ferrous, ferrous to ferric, it goes on. And that causes all the adverse events. And that is why, it is always made stable by combining it with some protein or something, or a glucose derivative, That is why, it gets optimal absorption and compliance also goes on. So this is going to be a real problem for us. And then, again, when we see the unabsorbed iron, the naturally, for the compliance, we used to ask the patients whether their motion is stained black or not after the bowel movements. And that is how we used to know whether they are compliant or not. But unfortunately, many times the ferrous sulfate tablets, which were given to us by the government, they used to lose their covering. And then, many patients used to throw them off and never use them also because of the adverse events. And some of them actually used to come and say, yes, my bowel movements, after my bowel movements, I find dark colored motion, because they knew that is what we are going to ask, like in oral examination, however, people will exchange notes. So that is how it went on. So the optimal elemental iron at right time for optimal absorption and compliance is very, very important for us, that way. And how much iron to give? Because you see, we used to say, because what the government of India said in anemia prophylaxis program, where they supplied is, for a prophylactic purpose, 60 milligrams iron, elemental iron is sufficient. And then for people who are really anemic, 120 milligrams. That means BID 60 milligrams. So our people were never able to tolerate this amount of ferrous sulfate. And that is why, people were giving it up. And we found that the anemia kept on increasing. And then of late, we started depending upon the injectables, first iron sucrose, and then came the ferric carboxymaltose. And we started giving them. But then, the expenditure, like you said, it is expensive. And most of the governments, they do not supply in the public hospitals. So the patients have to buy that. And then the adverse events, like you said, we have to sit with the patient so that there is no adverse event. And we cannot give it up also. So then, this became a little problem. And that is the reason, we are looking out for something which will really improve the hemoglobin, especially in our pregnant patients. And not only in pregnant patients, even in school health clinics, we would like to give them this iron tablets to our adolescents. And we have a program, school health program, where, the adolescent girls and boys are also given deworming, and then, one iron tablet, ferrous sulfate, once a week under the supervision of the teachers. But in spite of that, it is not improving at all. At our National Institute of Nutrition based at Hyderabad, they are doing some studies as to see, even when they are compliant, why their hemoglobin is not increasing. Is there something in the gut which is preventing the absorption? Like you said, the dysbiosis may be one of the factors, which may be preventing the absorption also, perhaps. We don't know. And these are the problems, we are all grappling with. And I think ferric maltol may solve these problems. And I hope we have a good molecule to give to our pregnant patients. And especially, after giving a injectable iron, suppose the woman has, 6 grams or 7 grams hemoglobin, and we give a dose of ferric carboxymaltose, and it goes up to 10, that is not sufficient for us. We have to start giving them oral also afterwards. So whether ferric maltol can take over here, so that is going to be a problem for us. And then I think we need studies to see whether our pregnant patients can tolerate this molecule and then continue to improve their hemoglobin, so that when they reach their labor, at least they have 11 grams hemoglobin, so that there won't be any problems of collapse, because postpartum hemorrhage is a common thing in anemia, and as we all know, 25% of maternal mortality is contributed by anemia in our country, at least. So I think, this is a very important step where we can find a good molecule which is going to be tolerated by our pregnant patients and which can be given to them to improve their hemoglobin right from the adolescent age, so that, when they embark on pregnancy also, they would be with a good hemoglobin content, they'll be embarking on their pregnancy. Dr. Prashant, have you got any questions for Dr. Schmidt in the chat box?
Yes, ma'am. Ma'am,
Yes, ma'am.
I would
Just a second, Dr. Pallavi. So there are, ma'am, questions, but I would request you if you can take few of the slides which Dr. Pallavi is displaying. But ma'am, before that, I would also request Dr. JB Sharma sir to share his views about this molecule. Yes, thank you, ma'am.
Yeah, Dr. Sharma?
Please unmute, sir.
Okay, can you hear me now? Yeah. Oh, okay. So thank you, Dr. Smith, for your excellent talk. It was really a mesmerizing talk. And what I can make out points that, as compared to placebo, that there was rise in hemoglobin of 2.25 gram. And only thing, as Madam Balamba was also saying, like our patients, the patients in your studies were mostly 40 years age, median age. And for the study on chronic kidney disease, they were rather 68 years old. But most of our patients in pregnancy will be like in late 20s or early 30s. So that is one difference. They will be 10 years younger than that. But that is a favorable point also, that older one becomes, then more chances of some GI intolerance and other associated comorbidities also. So that is a favorable point. And you compared the results with the placebo. So but the adverse effects were, and patients stopping the medicine were less than 5%. But on the other hand, when we are using ferrous sulfate, as Ma'am Balamba was also saying, so our patient stopping medicine may be anything between 30 to 40%. So so that is really promising. And my only this thing is that because none of the studies have been done on pregnancy. So on that day we were discussing with Dr. Balamba, so that was like, because I feel that ferric maltol is just synonymous to probably ferric maltose to some extent. So there is no reason why it should not be safe in pregnancy. And another thing I want to know that, like, as Dr. Balamba was saying, so traditionally we are using, and Government of India, WHO also recommend 60 milligram elemental iron with 500 microgram of folic acid to all pregnant ladies if their hemoglobin is more than 11 gram. So that is prophylactic, because the prevalence of anemia in India is more than 40%. So prophylactic iron is required for every single woman in India during pregnancy. And if the hemoglobin is less than 11 gram, that means if they are anemic, then we give them double the dose, as Dr. Balamba said, to 120 milligram elemental iron. And usually when they have anemic, we give them 5 milligram folic acid also along with it. So that is this thing. So you said that 30 milligram of ferric maltol is to be given once a day or sometime twice a day, you said. So I want to ask, can we like equivalent dose? So that means if we are using ferrous ascorbate, this Oroferxt, Ferrimext from our Emcure company only. So equivalent to, so what I used to do, that I used to use 100 milligram of Oroferxt or Ferrimext once a day for prophylactic, and one tablet twice a day. That means 200 milligram elemental iron for therapeutic purpose if the patient hemoglobin was less. So equivalent to that is 30 milligram of ferric maltol is equivalent to 100 milligram of ferrous ascorbate or other iron salts. And similarly, like 30 milligram BD, is that equivalent to 200 milligram of ferrous ascorbate? That I want to know from Dr. Smith, number one. And number two, that like, has any study being done in pregnant ladies? Why the pregnant patients were excluded? Was it like because these are the patients who actually are the biggest beneficiaries? In fact, pregnancy anemia is the commonest anemia which we deal with in our daily life. So these are certain points I want to highlight. So probably there is a real need to have, because I feel if it's only less than 5% patient dropping the ferric maltol, that is a very, very good point. And that really, that means it appears to be a magic capsule, if that is true actually, and especially pregnancy ladies. But it also happens, Dr. Balamba is smiling, that initially when any molecule comes up, and we have great hopes, and after a few months or years, then it also becomes just like any other molecule. So thank you very much, but for the excellent talk. Yes.
Thank you. Well, with regard to your second question, due to regulatory requirements, it is very difficult in Europe to do any study in pregnant women. This is a real challenge, and so the results mainly result from patients, especially from pregnant women who already took the substance during their pregnancy. We collect data and try to learn from those patients who, let's say, accidentally took a drug. I advised the company who developed ferric maltol to do a study in younger women, to do a study in women's health in general, even if not in pregnancy. But unfortunately, they did not do so. And so I really hope that you will be able to do such a study, and I'm really keen to read it in the near future, because I think that it is really important. We know that the drug does not appear in the systemic circulation, and therefore I don't expect any adverse events in pregnancy at all. And as we learned from the WHO, it was said in last October, I think, that it may be used in pregnant women and that it can be used in lactating women. So there is an opportunity to use it already in pregnancy and during lactation. And I think that you should collect those data to learn from this patient population. With regards to the dosage, we did not do an equivalent study to compare ferrous products with ferric maltol. But we know from a pharmacokinetic study that there is obviously a kind of saturation, because if we gave those patients with Crohn's disease and ulcerative colitis 30 milligrams BID or 3 times a day, 60 milligrams or 90 milligrams, there was absolutely no difference in the serum iron concentration. So there's, from my point of view, a kind of saturation that doesn't make it reasonable to further improve the dosage in order to replenish iron stores even more rapidly.
Thank you. Thank you. I think it makes sense. Yeah. Dr. Prashant?
Oh, yeah, ma'am. So, thank you, sir. And thank you, ma'am, for this lot of discussion we had about ferric maltol based on the clinical trial evidence what sir just spoke about. So there are lot of questions from the audience. So I will take it up one by one. So the very first question, which is there from the audience, is that what are the so this I would like to address it to ma'am, Dr. Balamba, ma'am. So I think you have already highlighted, but still, the audience want to know, one of the doctors in the audience, what are the current challenges in managing anemia effectively? And after listening to Dr. Carsten Smith talk about ferric maltol, so how it could offer a new perspective in addressing these current challenges with the conventional salts which are there in the market, like ferrous fumarate and ferrous sulfate. So how it will be helpful?
Yeah, I think, we require a multicentric study, first of all, because this is going to be introduced. And I think we have to compare it with whatever ferrous salts are available, so that, we know about the adverse effects also. And it can be, multicentric studies, it can be a crossover study also. So that, we know which molecule is better tolerated and at what dose. And the lower dose, if it is going to work wonders, then, we would prefer that, because the lower the dose, the less will be the adverse effects also.
Absolutely.
Even if they are there. So that is going to be very important. And if it is 30 milligrams, you see, because nowadays in Western countries for mild and moderate anemias, they are not even prescribing daily doses of iron. They are saying weekly once or twice is more than enough. Because if that is going to be absorbed, that is very good. Because pregnancy is a state, where actually even though the hepcidin is high, still the absorption of iron goes up. It is almost up to 25 to 30% compared to the 10 to 15% in non-pregnant women. That is because the iron stores are depleted very fast in pregnant women. So I think, this 30 milligrams, if we give, the entire thing is going to be absorbed. And then, we may not have any much of adverse effects because nothing is left in the gut to create the adverse effects also, isn't it? So that may be one of the reasons. But I think, we do require studies. And once we get that molecule, we can try. And each obstetrician can try on 10 patients. There are so many obstetricians, we have number of pregnant women who can try this molecule, and we can produce a paper also, and we can find out also whether this really works or not.
Absolutely.
Pregnant women.
Absolutely, ma'am. So just like I wanted to ask Dr. JB sir, as ma'am also mentioned that the 30 milligram would be a good option for those who are having mild cases of anemia, mild to moderate maybe. But my one concern was there, like because right now we are using 60 milligram maybe twice daily, or as even we have 100 milligram ferrous ascorbate. So in the mild anemic cases, like especially in the second trimester when the doctors are using it, especially, so will there be a need of 60 milligram given twice daily, or would there be a need of 30 milligram which would suffice in the mild anemic cases? Because as per the NFHS data, which you also mentioned in the start, as per the recent NFHS 5 data, which mentions mild anemic cases, whether it is a non-pregnant category or pregnant category, it is like bigger chunk like compared to the moderate or severe, because the severe is the
Yeah,
it's
I
very
think
big.
that is the advantage of ferric maltol, I
Absolutely,
I
ma'am.
feel. Because 30 milligrams, if it can improve the hemoglobin, why should we go for a higher dose? Like I
Yes,
said, the higher the dosage, the more the
more
adverse
the
effect.
side effect, more the adverse effect.
Yes, yes.
So,
Definitely.
yes, sir.
I mean, I feel like, as I asked Dr. Smith also, so I feel for patients of normal patients with hemoglobin more than 11 gram, or maybe mild anemia, like especially 10 to 11 gram, so 30 milligram once a day may be adequate, because the absorption is more in this case, more than 10%, like in traditional iron only 10% absorption is there. So even if you are giving them like 60 milligram, so they are absorbing only 6 milligram, maybe a little bit 6 to 7 milligram. But if we are using these products like iron maltol, the spheric maltol, and some, so then the absorption tends to be maybe 15 to 20%. So equivalent amount, I mean, maybe from 30 milligram, or about 10 to 12 milligram may be absorbed, which may be adequate. But for patients of moderate anemia, maybe mild anemia also, I think 30 milligram twice a day will be needed. So I feel 30 milligram OD is prophylactic dose, 30 milligram BD will be therapeutic dose, just like we used to 60 and 120, as Dr. Balamba said. So equivalent to that, and even that will give actually adequate absorption of maybe 15 to 20%, because traditional iron is 10% absorption, and in the Indian diet, where essentially we are eating a lot of wheat and
Yes, sir.
rice,
Yes, sir.
tannins, etc. So absorption is sometimes less than 10%, 5 to 10%
Sure.
only.
So my next question would
No,
be,
that the reason is, that is why we should give these tablets before food, at least 1 hour before food. And if the adverse events are less with this particular molecule, I think, it will do the job of improving the hemoglobin, even if it is given not after food, but before food. Yeah.
yes, sir. Thanks for that clarity. My next question would be addressed to Dr. Carsten Smith, sir. So there are like a lot of queries which are coming up about the clinical evidences which are available, as I believe the clinical evidences you have already displayed for IBD, CKD patients, but they wanted to know whether there are any cases in the pregnancy for the pregnant woman, like in the management of IDA, but they also have a query whether what could be the implications if it is given for a long term, whether the long term adherence or the compliance would be there, because usually when the patients are on the salts for the oral preparations, so they discontinue, like maybe in 2 or 3 weeks. So there is not, they don't see any good compliance with them. So for this molecule ferric maltol, like in your clinical trials, have there been any long-term treatment where the patients have been given for more than a year or so, so that they wanted to understand?
Well, to start with your last question, the trial ended after 64 weeks. That was the longest duration
Yes.
that we treated the patients. So there's no experience with longer treatment period. I think on the one hand side, I would not expect any adverse events after a longer treatment period. But on the other hand, we should question if it is really necessary to treat patients longer than a year, because in absolutely most cases, iron stores should be replenished after such a long treatment period, and I think therefore it will not be necessary to treat for a longer period of time. With regard to the first question, if there are any data in pregnancy, there was only a recent poster published at the UEGW meeting last year, summarizing the experience from a colleague of mine of 27 women with 29 pregnancies, where the women received ferric maltol mainly at 30 milligrams per day, only a few patients with 30 milligrams BID, and they did fairly well. They improved their hemoglobin as described before, and they did not experience a substantial number of side effects, and the children were all very well.
Yes, sir. So, ma'am, I wanted to ask you one thing, because as in like in US and Europe, as the molecule has been approved by the US FDA and European Union, so it is a single entity, it's a single moiety. But in India, what we are going to launch, so it will be not only ferric maltol, it will be with some kind of micronutrients in it, like vitamin D, vitamin C, B12, and folic acid. So some doctors wanted to know like what could be the role of adding D2 in this formulation, because yeah, so that's what they wanted to know. So
Most of
could you?
our patients are deficient in vitamin D also, and which is very essential, especially, because nowadays we don't say vitamin D is a vitamin. We call it a prohormone, as a matter of fact, and because, that is very essential, because calcium also has to be absorbed. If the vitamin D is low, calcium cannot be absorbed. So that is very important for us. And then vitamin D, as a matter of fact, is the daily requirement during pregnancy is supposed to be 2000 units. So adding vitamin D makes sense here. And of course, the micronutrients are important, because folic acid, we all know, is very important. And another thing that we are finding off late is deficiency in vitamin B12. Almost every person, whether pregnant, we are not testing them, but even non-pregnant women, and especially PCOS girls, they're very deficient in vitamin D and also vitamin B12. So these women, these patients, they may require a combination of drugs. Of course, Western countries, they don't approve usually of combinations, and that is why they don't market it there. But in our country, we are used to these combinations. I think it does make sense to give all these things.
Sir, I wanted to ask doctor. Yes, sir, ma'am. Thanks for that clarity. But where we have came across like vitamin D, C, or B12, they also help in the formation of the red blood cell. So is it necessary? Will it be helpful if we add D2, and it will help in the formation of the red blood cells also? So will it be good for the process of erythropoiesis?
So far we have no evidence that vitamin D helps in erythropoiesis, at least. But folic acid and pyridoxine also is very important to that matter, vitamin B12. These three are important for anemia. And nowadays, now they say even for prevention of neural tube defects, choline also is important, yes, apart from biotin also, So these are all the new additions, because folic acid, in spite of supplementing, sometimes there may be some neural tube defects despite good folic acid supplementation. And that is where, this biotin and choline are coming in now. Yeah.
Yes, ma'am, because I stand by your words, because if I talk about the IDA, so the data speaks from the NFHS, like out of two, at least one woman today is having the problem of of the IDA. But if I talk about the vitamin D deficiency, out of four, at least one woman are like deficient in the vitamin D. So if we are adding vitamin D to the formulation, it will definitely be helpful for the pregnant woman. So thanks for that. So my next question would be to Dr. JB Sharma, sir. There are some questions like some doctors wanted to know what patient population would benefit mostly from this ferric maltol therapy. So we have heard Dr. Carsten Smith's lecture. So what, according to you, which patient population will be helpful with this ferric maltol?
I feel pregnancy anemia will the pregnant ladies are will be the biggest beneficiary, followed by lactating patients. But as Dr. Balamba said, it can be used like in maybe in anemia mukt warts and others in adolescent girls also, and including children, both boys and girls actually. So in reproductive age group, I mean mainly females, but otherwise in children, boys can also be given, adolescent girls and women of reproductive age group. But most biggest beneficiary will be pregnant and lactating ladies. If ultimately when we can prove that it is, safe in pregnancy and all the necessary approvals are done, and we can do some studies and prove efficacy, safety, which I
Yes.
feel should be there. So they will be the biggest beneficiary, because this molecule can be actually tolerated well by the patients and we are getting results. My only worry sometimes is that we had preparation before also, they were slow release preparations. So the companies claimed they were very expensive, 3-4 times more expensive than simple ferrous sulfate, and companies claimed that the drug did not cause any side effect. But what happened? The drug went and it never actually got dissolved in duodenum, and there was no absorption. So patients were not having any side
Absolutely.
effects, but they were not having any effect also. So we don't want that actually. That is the
Yeah.
worst.
Correct.
So based on this same statement to Dr. Carsten Smith, as I heard you talking that this molecule will not have any systemic side effects and it will be not seen in the systemic circulation as well. So have you tried this molecule in any of your patients who are adolescent, or do you have any experience in treating for these patients? Where
Unfortunately
in
not,
India,
because
where we can see being 30 milligram, and as we got to know that this molecule will be devoid of any side effects, any systemic side effects. So doctors would like to use in this population. But may I have your experience on this?
unfortunately, I do not have any experience because my patients are 18 years or older and there haven't been any studies in adolescents. But I think this is obviously very important and again, a vulnerable patient population. But there should be additional studies to prove efficacy and safety in younger patients.
Okay. So next question would be for mild iron deficiency, of HB of less than of in the range of 10 gram per deciliter to 11 gram per deciliter. How would you recommend the dosage? Will it be once daily or twice daily?
Who are you asking this question?
To anyone, ma'am.
I think
It's
one
open,
should be
I
all
can
right,
ask
because
you
if
as
it is
well,
between 10
because
and 11,
being in India.
if it is between 10 and 11 grams,
Hello.
I think 30 milligrams should do. 30 milligrams should do.
Well, actually, I must say that I would prefer the BID dosage, because we know that as long as the anemia occurred, iron depletion already occurred as well, and it takes time to replenish iron stores. And therefore, I would suggest to use the higher dosage to check the iron stores and to stop the treatment when iron stores are already replenished.
So you would like them to do a ferritin and see whether it is, and the transfer
Right.
in saturation.
Yeah. For example, after 3 months, and if the ferritin is normalized, I would stop treatment.
Yes. So there is a next question is there. Is this molecule approved in pregnancy? And if it is approved, so which category? So I believe till now we have heard from Dr. Carsten Smith. So this molecule, it's not about approval, but in the foreign country, they have not been tried in pregnancy. But as per the data from the European Union, for the brand, there is one brand called Acrufer. So in the pregnancy, it has been shown that it will be not having any teratogenic effect on the fetus. So that's what we have learned about this molecule. So it can be safely tried in pregnant women also. So that's what I understood from the session. If I'm wrong, Dr. Carsten Smith, please correct me.
Correct. That's what the EU says.
Yes. So what about the ferritin levels with the maltol? Because that's what question came up 2 days back also. So any comment on that, sir?
You mean the level of ferritin that I would like to
Yeah,
address?
so will it be having a good like rise with this ferric maltol, or only it will be helping to rise the HB levels?
Well, I think the first treatment goal is normalization of hemoglobin, and the second is normalization of ferritin. But there's no specific goal in ferritin levels that I would like to achieve. I would like to see a ferritin level that is far within the normal range, and then I would stop treatment pragmatically.
Anything
so-
above 30 should be all right. Any ferritin level above 30 should be all right.
All right, yeah. So in your clinical study, Dr. Carsten Smith, so were there any kind of major gastrointestinal side effects which you could observe, or it was manageable and it was mild in intensity?
There was only one patient in the entire studies who are suffering from ulcerative colitis, who experienced a disease flare that was not attributed to the ferric maltol treatment by the treating physician, who stopped treatment because of GI side effects. But that was only one patient among several hundred patients who were suffering from IBD.
Okay. And any interaction with food or calcium, sir, while giving ferric maltol?
Well, the patients were required to take ferric maltol apart from food and apart from other drugs, including calcium. So there are no clinical data showing an interaction, because this kind of interaction was excluded within the studies.
Okay.
By and large, we don't give calcium and iron together.
Right.
Iron should be given before food, and calcium
2 hours,
should be
yeah.
after food. Yeah.
And
Yes.
like Dr. Smith, basically, like traditional irons are better absorbed in presence of acidic environment and ascorbic acid. So that's why this Emcure came with ferrous ascorbate and all. So is it like sometimes we advise the patient to take like iron tablets with lemon and lemon water or something like that. So this orange. So do you think ascorbic acid or lemon water, etc., will have any effect on this molecule, ferric maltol, or it has no relevance?
Actually, I assume that there is no effect, because the main effect of ascorbic acid is the reduction of ferrous to ferric iron. And as we already give ferric iron, this process is not required. And therefore, I think the absorption of the process is independent of ascorbic acid.
Okay. So similarly, like heme iron, I mean,
Right.
meat preparations and all, they will also have no
Yeah.
effect on it, no?
Yeah.
Also, but in case if ferric maltol is given with vitamin C, will it be harmful, or will it cause any harm to the patient or any negative impact?
I don't expect any harm at all.
Okay. So the next question to Dr. JB Sharma, sir. So some of the doctors are like wondering whether we can use ferric maltol safely and legally. So what is your take on this?
Safely and legally. That I think more than me, you should answer. Like, I mean, do we have approval of DCGI for
So we have,
use in pregnancy?
yes. So to answer this, we have applied to the DCGI and we are awaiting the revert on the same. Yeah. So that is what I
So
would
you
say.
have mentioned
But,
pregnancy also there, no?
yeah, but if I talk about safety, yes, it would be safer, because till now we have heard about the safety aspect. It will not lead to any major GI like disturbances, and it was not seen in the systemic circulation. But about a legal point, yes, it will be soon approved by the DCGI.
No, unless it is approved, it will be an off-label use.
Absolutely.
So we'll have to wait for that approval. Yes.
But as a doctor, we can use off-label drugs, but in selected patients, or sometimes as a part of thesis protocol or research setting, we can easily use the drug after taking ethical approval from our institute. If you are
No, that is why we're
approval.
suggesting a multicentric trial, so that we have studies.
Absolutely. Absolutely.
Our
It
own
is a need
study.
of the hour. Yes.
Yes.
So the next question to Dr. Carsten Smith. So in your trials, where you have done for IBD and CKD, so I believe 30 milligram twice daily, or was it increased to some extent for IBD, CKD, and pulmonary hypertension?
There was a lack in transmission. Could you repeat the question, please?
So what he wanted to know was whether in CKD, IBD, and Pulmonary
I'm
hypertension.
sorry, ma'am. There was some issue with the internet. I will repeat the question once again to Dr. Karsten Smith.
Thank you.
Yeah. So there are some doctors who are asking, like in your clinical trial, where it was done for IBD and CKD, so was the dose 30 milligram twice daily, or was it increased to some extent?
No, it wasn't increased. It was a fixed dose, 30 milligrams BID.
Yeah, I have a question for Dr. Schmidt. See, in chronic kidney disease, it is the erythropoietin which is also deficient. So without erythropoietin, do you think this ferric maltol is going to be absorbed?
Very interesting point.
used
Very
to-
interesting point. No data on this point because the patients didn't receive erythropoietin, but that's an interesting and especially scientifically interesting aspect.
Yeah, because I feel that when the patient has got CKD, in our practical experience, this erythropoietin is less and blunting is also there. So they require erythropoietin therapy, and when we are giving erythropoietin to them, then the bone marrow becomes so much thirsty that oral iron is just unable to cope up. So we tend to give actually ferric carboxymaltose to them, like in the regime which I use in my hospital. If I'm giving them for CKD erythropoietin, I tend to give them about 18,000 units of erythropoietin. But along with that, I give them 1,000 milligram of FCM IV. Because the bone marrow suddenly stimulates and it becomes so much hungry, for iron, that oral iron is just unable to cope up.
Even in HIV patients, we do give. When zidovudine was being used, it causes bone marrow suppression. And in those patients also, we have to give erythropoietin plus IV iron,
IV iron, absolutely.
So the next question to Dr. Karsten, because I believe the trials what you have done, those patients were mild anemic. So what could be the lowest possible HB levels where this molecule could be tried, and what is the placement of this molecule against IV iron in moderate anemic patients? Because I believe there is a trial of ferric maltol versus IV FCM. Okay, so
well,
if
in
you
this
could
study,
put some light.
the lowest level of hemoglobin was 8. It was between 8 and 11 and between 8 and 12 in males. So it was not only moderate, it was quite severe anemia. And even if the mean hemoglobin level was about 10, there were a substantial number of patients with lower levels of hemoglobin. And ferric maltol did completely well in both patients group with higher and with lower hemoglobin levels.
And one more question: what is the highest dose of ferric maltol which can be given in a day? Like, is it just 60 milligram, or can we go up to 90 or 120 also?
Well, in the clinical trials, the highest dose was 60 milligrams per day. And as I mentioned before, in a prior pharmacokinetic study, we showed that the increase in systemic iron concentration was not different between 60 milligrams and 90 milligrams. So we can assume that a higher dosage does not transfer to greater efficacy.
Mm-hmm. Okay.
Yes, so there are a few more questions. So if you don't mind, can we extend for more 10 minutes because it's already 9:30? I do understand. So if you allow, I can ask some more questions because there are a lot of queries.
Go ahead.
Dr. Karsten.
Yeah, sure.
Yeah.
Yeah, ma'am. So with your permission and with your Dr. JB sir's permission, if we can extend for more 10 minutes.
Yes, please.
Yeah, thank you, sir. Thank you, ma'am. One more thing, Dr. Karsten. So what could be the possible contraindication for this new molecule, ferric maltol, or can it be safely given to patients of thalassemia? Because one of your slides may mention that iron uptake with ferric maltol is saturable, thus avoiding the potential for iron overload. So can it be given safely for thalassemia also?
There are no clinical, no scientific data in thalassemia, but I assume that it can be given. And from my point of view, there are no absolute contraindications. There may be a contraindication in the rare case where patients experience side effects on ferric maltol, even if this proportion is quite low. But in this a group of patients, we obviously would choose another preparation like IV preparations, for example.
Can I add something here? See, in these patients, I think we better do a ferritin level. And the ferritin is very high in these thalassemia patients, better to avoid, so that you don't cause hemocirrhosis by overloading them with iron. So that is going to be a problem. So if at all you are giving in thalassemia minor, it may not be of much problem, but thalassemia major, definitely not, unless you do the ferritin. There we give only
I totally agree with you. I just think about patients with thalassemia in rare cases who already have a different entity leading to blood loss and who experience low levels of ferritin, who experience iron deficiency, even if this is a quite rare event.
Yes, thank you, sir. Dr. Carsten, sir, do the stool turns black with this tablet? Any data on that?
Yeah, it turns.
Okay. So Dr. JB, sir, or ma'am, if you could answer this, will this molecule be safe during pregnancy in the first trimester?
We don't give it in first trimester anything new, because there are legal problems. And then, in the first trimester, anyway, they are having hyperemesis. And anything you give, they are going to vomit. And more so with iron. So I think, it's better avoid, because if at all we diagnose some anomaly, they may attribute it to this tablet. So I think, it's better to avoid giving any new molecule, especially which is not established during the first trimester.
Not only new, we don't give any iron in first trimester, madam. Unless if the patient has got genuinely severe anemia, then we tend to give, like someone is 2 to 3, 4 grams, then we usually give blood transfusion in first trimester. But most patients will not require, and we don't give any iron. And for the reason is that it is not teratogenic actually. For that matter, iron is not teratogenic, but generally because there is a background 2 to 3% malformation rate, so the unnecessary blame will go to the iron or whatever molecule. So other than folic acid, we don't give any medication in first trimester unless absolutely necessary. And the new molecules must not be given actually when we are not giving him older molecules. I mean, it should be very clear to the esteemed delegates and faculty that, it is just like, it is also a type of oral iron preparation. So all the indications, contraindication, I mean, everything else is similar to the oral iron, other traditional iron. Only thing it is because, like as Dr. Smith has proven, it has got much better GI tolerance effect. And he has proven, in his studies how the molecule is surrounded by all around, and that's why it doesn't cause any irritation of the GI. But I feel once it is absorbed, then it is just like any iron. So I feel the GI side effects will be much less, and these are the GI side effects because 70-80% are GI only, which cause actually patient to stop iron. But once it is absorbed, it is in the systemic circulation. And if some patient have got suppose headache or those systemic side effects, so they theoretically can be, they're here otherwise also, but they can be there with this molecule also.
Absolutely.
Only thing GI will be much less.
Absolutely. So
the advantage is, when Dr. Schmidt has tried it in the inflammatory bowel disease, where there is an inflammation in the bowel, so the side effects are supposed to be more with the iron. But even there, they found very less side effect. So in a pregnant woman who has no bowel problem, it should not be a problem.
Yes, much less. So there is there are a lot of observation from the doctors that the study, whatever we have highlighted, or it's available. So it talks about the superiority of ferric paltol versus placebo and non-inferiority with regards to FCM. But as they have also pointed out, there should be a study showing the superiority over other conventional oral irons. So that is the need of the hour, which being part of the Emcure will be taking care of it. And I assure sooner it will be there online where we can talk about this molecule versus the conventional oral iron preparations. So the next question would be to Dr. Carsten Smith. Yes, sir.
Yes, one comment only. I think you're totally right in terms of efficacy, but in terms of side effects, it already has shown superiority because, as I mentioned, all the patients, or 2/3 of patients, experience side effects, and they did not experience side effects on ferric maltol. So in terms of side effects, superiority has already been shown.
Yes, sir. But one thing for the Indian context, doctors are concerned about the gynae patient, of the pregnant ladies, how it will fare in the second trimester. like
Yeah.
especially the mild anemic cases. Although we have shown the like safety part in your clinical trial, it is superior to the conventional salts. I do believe that. But for the efficacy per se, I do understand that whichever salt we are trying today, whether it's a ferrous fumarate or sulfate or whichever other salt, they all have almost the same rise in the HB, like from 1 to 2 gram per deciliter in 4 weeks.
Yeah.
So, like I believe for Indian context, it will not be more about the efficacy, but about the safety, because that is the main reason where the patients are non-compliant and non-adherent, and that is the main issue with the oral iron preparation, for which they shift to IV preparation. It could be the mild or moderate. Ma'am, correct me if I'm wrong.
Yes, yes, you are very correct. And that is the reason, and especially the other advantage I'll tell you, because, we want their hemoglobin to rise faster.
Absolutely.
And very carboxy maltose, it scores over that.
Absolutely, ma'am.
Because
And-
it's faster. The faster rise in hemoglobin. Yeah.
Absolutely, ma'am. And from Dr. Carsten Smith's one study, what we could find that even this ferric maltol have a faster HB rise, which is 1 gram per deciliter in 4 weeks. So, right? If I'm
Yes.
right with this data? Absolutely. So it is also having that property of like raising the HB faster.
See, the problem is, nobody should expect the hemoglobin to rise in 1 week, because the erythropoiesis itself takes 3 weeks.
Absolutely, ma'am.
So naturally, from the erythroblast to the RBC, the cycle is 3 weeks. So even if you give iron for the hemoglobin to improve, it has to be at least minimum 3 weeks.
Yes.
So before that, you can't expect any miracles.
Yeah.
So you'll have to wait for that.
And
so
the,
now-
the results like what Dr. Smith has shown, they were in non-pregnant patient where definitely hemoglobin rise will be there. We have done study including with injectable iron. I mean, that was older study when FCM was not available and oral iron. So some of the patient we could there was hardly rise of 0.5 gram. And then, it's not a failure. Or suppose if you are able to maintain hemoglobin of 10 gram, this is because normally there is hemodilution occurs. So if I don't treat that patient from 10 gram, it will fall to 9.5 and later 9 gram. So even if I'm able to maintain 10 gram, that is also an achievement. It's not a failure. So the rise will be much less in pregnant ladies as compared to non-pregnant ladies, and more closer you are to 11 gram, the rise is much less. But if it is more like 7.5 grams, then rise is more. So I mean, in pregnancy, I will not expect 2.5 gram rise in
the oral
this
preparation.
thing. But even like half gram, 1 gram rise, or even maintenance of the hemoglobin to 10 to 10.5, because if you don't give, then it will drop to 9 gram, then 8.5 or 8 gram like that. So that is pregnancy is little bit different as compared to non-pregnant state.
Yeah, ma'am, to you this question like from one of the doctor, like can this molecule be given to those patients who are intolerant to the conventional oral iron in the second trimester, maybe ferrous fumarate or sulfate?
Yeah, we can give. That is what we are all telling now.
That is the whole
Yeah.
purpose.
Yeah, means can they be shifted if they are intolerant, so they can be shifted to ferric maltol?
we can try. No harm.
Yes,
We can.
absolutely, ma'am. So, through Dr. Carsten Smith, sir, since it has been shown in the literature that compared to the conventional oral iron preparation, which are mostly salt-based preparations, so ferric maltol is a non-salt preparation. So, being a non-salt preparation, and the data also speaks that there is no dissociation of the salt in the stomach, being a ferric maltol structure. So, will it make any difference in the efficacy if it is taken with food or before food? Because yes, sir, please.
We assume that there is a difference. There is no formal study showing this, but it has been suggested that the mixture with food may reduce the time it is attached to the mucosa, and therefore it may be absorbed at a lower percentage. But there are no formal studies showing this effect.
Okay. Yes, sir. So one question to you, ma'am. Can this be given as a once daily preparation for those who are non-pregnant category, maybe 30 milligram? Will it be like sufficient for the non-pregnant, or there also we should try with twice daily?
No, I think 30 milligrams should do, where they are non-pregnant and where they can take it and where they are tolerating this dosage. That should be enough. And it, like it is said, it is in the mild and moderate anemias, not severe anemias. Severe anemias, it will take a longer time for them to improve, if you are going to give oral salts. So,
but I think Dr. Smith can also give his opinion. Dr. Smith, is it that you are recommending 30 milligram BD? Is it that the blood levels are maintained for 12 hours or are the blood levels maintained for 24 hours?
I didn't get it completely. We did not check for the blood levels for 24 hours, but for 5 to 6 hours. And we saw from pharmacokinetic studies that was a peak between 2 and 3 hours and a decline thereafter.
So probably twice a dose will be better.
It's necessary, right? Yeah.
I think we should try to wind now.
Yes, sir. So it's done. So just one last point was there, like, can it be used in the young girls? So that I think we have clarified. It can be tried in the non-pregnant category as well. So that's said, like, from our end. So we have taken up most of the questions which came up from multiple locations as we have briefed. So this meeting is going on in 21 centers across India where we have been streamed live. So I would like to thank Dr. Karsten Smith, Dr. Balamba ma'am, and Dr. JB Sharma sir. So I will hand over the session to Dr. Pallavi, who will give the vote of thanks.
1 second. 1 second.
Thank you so much. Thank you, Professor, for wonderful presentation. And this was very enlightening and insightful. And I'm sure this will be very helpful and inculcate a confidence to use it here in India. And I also thank Dr. JB Sharma sir and Balamba ma'am for wonderful moderation. And thank you, Dr. Prashant, to be with me throughout the session. Thank you so much.
Thank you very much. And I thanks to all the audience who have participated and asked so many questions to make it a very interactive session. And I'm thankful to the team Emcure for conducting it very smoothly. Thanks to all. Have a nice day.
Thank you.
Thank you as well. Have a nice evening.
And I think if there are some more questions, they can be answered on email or later on.
Definitely, sir.
Yes, definitely.
But as per my knowledge, we have covered all the questions.
Okay.
Thank you, sir. Thank you.
So we also thank you.
Thank you,
and
sir.
Dr.
Thank you. Bye-bye.
Bye.
Bye.